So if there are no other questions, thank you. Your presentation was very nice and very crisp also. We are able to follow whatever you're saying, and good workup also done. Nice case presentation. Thank you.
Sir. Thank you.
So next case from SIMS Hospital, Dr. Parag Papalkar, an interesting case of jaundice.
So, good evening, teachers and my colleagues. I'm Dr. Parag I'm a second year DNB resident in SIMS Hospital. So, I'm presenting a case discussion on a challenging case of jaundice. So, our patient, a 45-year-old male, resident of Nellore, working in a ship making industry, presented with chief complaints of yellowish discoloration of eyes since last 6 months, but aggravated in last 2 to 3 days, pale colored stools and dark colored urine since last 2 to 3 days, and weight loss of around 5 kilograms in the previous 6 months. So initially, when he had presented with yellowish discoloration of eyes and urine, he first took alternative medicines after the onset of jaundice. This was 6 months back, but he couldn't tolerate the alternative medicines. He started having jaundice. He started having vomiting, so he stopped it by himself, and he consulted a general physician. On consultation with general physician, he was told that he's having jaundice, and he was worked up for the etiology in the sense that the viral markers were done, which were negative, and he was managed conservatively over the last 6 months. So in the course of last 6 months, he said that his jaundice levels were around the same almost all the time. But when he presented to us, he said that the jaundice has aggravated in the last 2 to 3 days in the form that his eyes has turned dark yellow, and he's passing dark colored urine also in the last 2 to 3 days. Even he told that he was passing pale colored stools also. So jaundice was not associated with any prodromal symptoms in the form of fever, joint pain, myalgia or arthralgia. There was no history of pain in abdomen, itching, vomiting, altered bowel habits, loss of appetite, bleeding tendencies or rash over the body, or no history of any hematemesis, melena, no history of pedal edema, abdominal distension or night sweats. He had a history of weight loss of around 5 kilograms in the last 6 months. Past history, he was a known hypothyroid. There was no similar history of jaundice in the past before the 6 months. There were no history of repeated blood transfusions. Family history was not contributory. Personal history, he was occasional alcoholic, maybe in once a week, and he consumed mixed diet. So summarizing the history, 45-year-old male is an industrial worker, social drinker, presented with painless jaundice without any prodromal symptoms, with cholestatic features in the form of pale stools and dark urine, with history of alternative medicines use after the onset of jaundice, having a weight loss of 5 kilograms in the last 6 months, and comorbidities in the form of hypothyroidism, with ECOG functional performance status of 1. Coming to examination, his vitals were stable, pallor was present, icterus was present, he had no cyanosis, clubbing, lymphadenopathy or pedal edema. There were no cutaneous markers of internal malignancy. Systemic examination, abdomen inspection was scaphoid, umbilicus was central, inverted. There were no sinuses, dilated veins or scar marks. Flanks were normal. All quadrants moving equally with respiration. No visible lump was seen. On palpation, there was no guarding, rigidity or tenderness. There was no organomegaly. Hernial orifices were normal. Percussion liver span was 12 centimeters. Robes space was resonant and no signs of free fluid. Auscultation was normal, bowel sounds were heard. Genitals and PR examination was normal. And other system examination also didn't reveal any abnormality. With this history, we first did the baseline investigations, which showed that he had a low hemoglobin of 7.2 and his total bilirubin was 34.3. So actually when he came to us 2 days back, he had a bilirubin report which was around 2.9. So in 2 days, his bilirubin has increased to 34.3 with a direct of 22.8 and indirect of 11.4. AST, ALT were elevated 347 and 110. Alkaline phosphatase and GGT were also elevated 907 and 433. Kidney functions were normal. INR was deranged, that is 2.27. He was a hypothyroidism, had a hypothyroidism, so we checked the TSH, it was 0.07. So with this, we wanted to work up for the etiology of the liver disease. Viral markers were negative. HAV and HEV was also negative. Leptospira and scrub IgM was negative. ANA was negative. And serum IgG was 1240, which is in the normal range. Ultrasound showed normal ecotexture of the liver, no organomegaly, and contracted gallbladder with some sludge. The other workup, that is autoimmune workup, ASMA and anti-LKM AMA was negative. Serum ceruloplasmin was also 0.3. IgM, HSV and CMV, it was also negative. So as you can see in this chart, this was over a course of 2 to 3 days when we were working up on his illness. So as you can see, this is the baseline investigation. Over the course of next 2 days or 3 days, his hemoglobin had dropped to 5.1 and his total bilirubin increased to 35.3. At this moment, we gave him one blood transfusion and his hemoglobin was 6.4, but the bilirubin kept on rising, that is 37.3. So basically, with this report, we thought that maybe some amount of hemolysis is happening because his hemoglobin is going down and bilirubin is increasing. So we wanted to work up for the hemolytic part of the illness. For the hemolytic workup, retic count was 2.7, direct Coombs was positive, 2 plus, serum LDH was elevated 2973, serum haptoglobulin was low. We started working for the hemolysis part. So G6PD quantitative was not deficient, that is, it was normal. FDP was more than 20, plasma fibrinogen was 286. Peripheral smear showed erythropenia and fragmented RBCs. D-dimer was 6.8, lipid profile was normal. HB electrophoresis was also not contributory. Urine for hemoglobin was positive. Actually, he started complaining of dark current urine, so that's why we tested for urine hemoglobin also. Having said that, urine for hemosiderin was negative and serum flow cytometry was negative for paroxysmal nocturnal hemoglobinuria. ANA profile in general was negative, and we went ahead and because he was an industrial worker, we thought of doing a heavy metal panel because that may be a contributory factor for the hemolysis also. So a heavy metal poison panel was negative in that it contained lead, which was negative. So this is the same investigations that I had shown initially. So in the hospital stay, he was treated with steroids, that is hydrocortisone. Hematologist advice was also sought for, and he was treated with folvite and Benadon. So with this rising bilirubin and falling of the hemoglobin, we did a plex for him for 3 consecutive sessions, low volume. As you can see, after the plex, his bilirubin came down to 13.5. Hemoglobin was stable. Further course of the illness was, so his symptoms improved basically, and he was discharged on oral steroids. On follow-up as an outpatient, he developed swelling of the right lower limb, and Doppler showed deep venous thrombosis. He was treated with oral anticoagulants. Steroids were tapered, and he was started on azathioprine. At that time, when he had come to the OPD, his bilirubin was 5.5, hemoglobin was 7.4, and at this time, urine for hemoglobin was negative. So basically, probably he was not having any hemolytic episodes in that moment. So at that time, ultrasound guided liver biopsy was done, basically to see that what is the cause for that high bilirubin. Autoimmune, if we are thinking of hemolytic anemia, generally they don't have that high hemoglobin. So we wanted to see whether we are missing out on any other pathology. Ultrasound guided liver biopsy showed ductular cholestasis, as you can see here. Sorry. So further, in the next 2 months, he was again admitted with us with febrile leukopenia, which was probably due to azathioprine. So azathioprine was withheld, and he was treated with steroids and antibiotics. So as you can notice here, when he was admitted this time, again his bilirubin was around 28.7, hemoglobin was 8.5. So after withholding the azathioprine and